this is indeed an honor to address this group this afternoon. I think this is an important time for us all in Alzheimer's disease, both research and on the clinical side of the house. So I'd like to take this opportunity to share with you some thoughts, at least N of one, just me, thoughts on where we are in the field with regard to making the diagnosis of Alzheimer's disease, as well as where we are in the treatment side. I've got a few things at the end if we have enough time. So here are my disclosures. I need to let you know why I'm cheating, lying, and stealing. On the left-hand column here are the companies that I do work with in a minor sense with regard to consulting on Alzheimer's disease treatment trials. The right-hand side is the NIH funding, largely, that we get to support our research endeavors. There's one there on the right that I want to point out, and this is the Alzheimer's Clinical Trials Consortium. I'm one of the principal investigators of this, which means that Clinical Trials Consortium, we work with companies. So we design clinical trials that involve academia, universities, and companies. But because it's federally funded, it precludes me from taking more than $1.50 from any of those companies on the left-hand column. So what's the ramification of that? I still drive a 1986 Dodge Diplomat. It does have a radio, it does have air conditioning. You can't have them on at the same time, but nevertheless, they are available. And here, is me heading off either to the golf course, the liquor store, or someplace. So, but more seriously, here's where I'd like to go this afternoon, is to talk a little bit about the field, where we are. And Rita and I were talking earlier this afternoon about the issue of, what's Alzheimer's disease? What's dementia? What's this thing called mild cognitive impairment? And where are we? So, as dull, uninteresting, I apologize, nomenclature turns out to be a big topic. So, I published a paper a year or so ago on this notion of the framework of dementia nomenclature. So, here we're talking about two elements in making the diagnosis of Alzheimer's disease. One is the syndrome. What does that mean? That means the clinical picture. Are you not remembering as well as you used to, not thinking quite as well? Is it affecting your daily function? That's the syndrome. And then we ask the question, what's causing that syndrome? Have you had a stroke? Do you have a tumor? Or do you have Alzheimer's disease? So separating out the syndrome and the underlying biology or pathophysiology is really important, and that's where we're headed. So we did this framework a couple of years ago, trying to characterize what are the clinical features of a person, what's the degree of severity of that clinical picture, and then what do we end up calling it as a syndrome. Then in the right-hand column, we add those what are called biomarkers, to the extent we know them, about the causes of the underlying clinical picture. So does the person have features of Alzheimer's disease biology, Parkinson's disease biology, stroke biology, and et cetera. So we put them together. So we start with the syndrome, and we label people then on their clinical features, either unimpaired, normal-ish, but with a little subjective cognitive decline. I'm not quite the same as I used to be. Mild cognitive impairment, we'll get into that in a moment, or dementia. So after we make that and we marry it with the biologic features by the biomarkers, then we come up with the disease labels. This looks like Alzheimer's disease, Lewy body dementia, frontotemporal degeneration, vascular cognitive impairment. So marrying the clinical features, the biologic features, we come up with these diagnoses. And that's important because we use these terms very loosely. And we, in the field, confuse people because we say somebody's going from mild cognitive impairment to Alzheimer's disease. Well, that kind of language is conflating the clinical syndrome with the biologic underpinning, and it may or may not make sense. What we mean is the person's going from mild cognitive impairment to dementia, and it may be due to underlying Alzheimer's disease. So that's kind of the dilemma, but it's very important. But we confuse everybody. We in the field confuse everybody with this. So back when I started decades ago, if somebody comes in with a memory complaint, we'd say, gee, are you normal? Or do you have dementia? And we got a little bit better at making the call of dementia earlier and earlier, but over time we realized that this is just a clinical continuum, and there's no hard and fast demarcation between normal, mild cognitive impairment, and dementia. Dementia means I'm not remembering, I'm not thinking as well as I used to, and it's affecting my daily function. That's the clinical picture of dementia. But this mild cognitive impairment thing is kind of in between. So I put as a subtitle for my talk is how much forgetfulness is too much? Well, I don't know, and I really don't mean to answer that question, but shed some light on why this is a difficult call, because probably mild cognitive impairment is too much forgetfulness. So this is the point at which people are starting to forget information they formerly remembered fairly well. It's important information, and it's happening repeatedly. So it happened a week ago, it happened today, it's going to happen 2 weeks from now, and people around you are starting to notice that your forgetfulness is different from what you're more forgetful. Dad, you got a tea time on Tuesday at 1 o'clock with your buddies and you don't show up. Okay, well, I was distracted, whatever. But that happened last week, and it's going to happen next week. That's probably too much forgetfulness. Doesn't mean Alzheimer's disease, but it does mean that maybe your forgetfulness is beyond what we would attribute to just normal aging. So, not normal aging, but yet it's not dementia. So mild cognitive impairment is, it's affecting my memory. I know it. My family probably knows it, but nobody else knows it. I'm still driving, paying my bills, doing the taxes, all that kind of stuff. I look normal, but my memory's not really what it used to be. So, putting all that clinical syndrome stuff then in the context of Alzheimer's disease, where have we come in the last few years? Well, we've come a long way because we're changing how we think about the disease. So when I started in the field, decades ago, again, we used the so-called McCann criteria, which were clinical criteria talking about Alzheimer's disease being a clinical pathologic entity. Not remembering well, I'm not thinking well, it's affecting my daily function, that's dementia. Okay, now I'm going to do a bunch of what we call rule out things. Make sure you don't have a brain tumor, a stroke, hydrocephalus. We don't find it, we'd say it's probable Alzheimer's disease. Couldn't say definite because we didn't know, and we couldn't say definite until the person passed away, had an autopsy, and we saw plaques and tangles in the brain. Definite Alzheimer's disease. That served us pretty well for decades because that's what we had to go on back then. But over the years, things have evolved such that we now have what are called these underlying biomarkers, indices of what's going on in the brain. And in 2018, a committee got together, led by a colleague of mine, Cliff Jack, up at the Mayo Clinic in Minnesota, who said, why don't we define the disease biologically? Not by the clinical picture, but by what's going on in the brain. This is what we do in cancer. So if you have a breast biopsy, it's positive you have breast cancer. Clinically, doesn't matter, you have breast cancer. Prostate biopsy, same thing. Excuse me, prostate cancer. So if amyloid and tau, plaques and tangles are the defining features of the disease, why don't we define Alzheimer's disease from that perspective, and then we'll be able to design trials and clinical efforts at trying to develop drugs that will treat it, et cetera, et cetera. But this was a major shift in thinking. I'm a clinician, so you're saying to me that I can no longer make the diagnosis of Alzheimer's disease in the clinic unless I have biomarkers that the person has amyloid and tau in the brain. Basically, yeah, that's the way it is. So, 2024, they evolved again, continued with the biologic definition of Alzheimer's disease, but a couple things that happened in the field that influenced them. One is there now were fluid biomarkers. Now, we've had cerebrospinal fluid biomarkers for decades, but blood-based biomarkers were now becoming available. Can we diagnose Alzheimer's disease in the blood? Maybe. I think we're getting there. I'm not sure we're there right today, but we're getting there. The other feature is that there have been 2 drugs approved by the FDA as disease-modifying drugs that are actually going to impact that underlying biology. So let's focus on that biology. This is a busy slide, don't worry about it. I'm just going to go through it. And the top line basically states that the committee felt that you could now diagnose Alzheimer's disease with these biomarkers. So if you have an amyloid PET scan, if you have a spinal fluid profile, and maybe if you have a blood profile, you can diagnose Alzheimer's disease biologically. This is a big deal. A lot of interest going on in the field regarding these various features of these diagnostic elements. But there's one that's been misinterpreted, and this is more for my colleagues who are knee-deep in this information. And that is, in the upper right-hand corner there, we have an amyloid PET scan. So if the amyloid PET scan is positive, does that mean you have Alzheimer's disease? If Alzheimer's disease now is defined by the presence of amyloid and tau, plaques and tangles, and this committee would say yes, if your amyloid PET scan is positive, it means that in your brain at this point in time, you have plaques and tangles, most of the time. Not all the time, but most of the time. That gets misinterpreted because it's an amyloid PET scan, so people are saying, you mean if I'm just amyloid positive without tau positivity, am I amyloid positive, do I have the disease? One would infer from that kind of a reading, yes, but that's not what they mean. They mean you have both amyloid and tau in the brain. On the clinical side of the house, they recognize that while it's not part of the diagnostic criteria, it's still very important. So cognitively unimpaired, MCI, dementia, important. And then they proposed a new staging scheme as well. So here's the earlier image that I showed, now superimposing Alzheimer's disease language on these different stages. They also proposed a clinical staging scheme which would help with the design of clinical trials. On the bottom there, stages of amyloid positivity. So if you were positive with an amyloid scan or a spinal tap, you had amyloid in the brain, then we would stage you. 0, 1, 2 are normal. 0 means you have a genetic predisposition. 1, you're squeaky clean normal. 2, you're normal but changing a bit. 3 is mild cognitive impairment. 4, 5, and 6 are mild, moderate, severe dementia. So here's where we've been. 1984, the clinical criteria were pretty good. I didn't talk about 2011, but this was an attempt to introduce biomarkers into the clinical picture. It was a step in the right direction. 2018, the change in the field that now biology was defining the disease. And then in 2024, now we can check that biology with even more subtle biomarkers, maybe even in the blood. So what are we talking about, these biomarkers in Alzheimer's disease? So here's a picture of what Alzheimer's disease looks like at pathology on the brain. The upper left there is a neurofibrillary tangle. That black thing is the tangle made of the protein tau. On the right-hand side there in the middle, we have that red thumbprint. That's an amyloid plaque. Those are two of the defining features of the disease. The other stuff frequently coexists and goes along with it, but it's those upper two features that define the disease. Well, we can see that in the brain now. We don't have to wait for an autopsy because we can see this amyloid protein deposited in the brain. So my colleague again, Cliff Jack at the Mayo Clinic, in 2010, 2013, and again in 2022, revised putative theoretical progression, anatomical and pathophysiologic progression of the disease, such that these were curves that have come to be recognized in the field as more accurate than not. The left-hand 3 lines there talk about the underlying biology and how you might detect it. As you move to the right, there are other indices of progression of the disease. The green markers at the right talk about the clinical presentation of the disease. And so what you can see is there's a gap between the biology on the left and the clinical presentation on the right. And that gap may be as long as 10, 15, or more years. That gives us an opportunity, a window of time to move in to try to intervene on this biologic process, to slow it down, stop it, or whatever. So that was very important. This kind of depiction of the temporal progression of the disease has been very important. What are we talking about with imaging? Amyloid imaging. Here's a PET scanner. Some of you may have been in one of these things. You put your head in them. They give you a little injection in the arm, and then they measure a bunch of stuff. What they're measuring is, does this protein, this amyloid protein, one of the defining features of the disease, exist in your brain? So on the left-hand part, we've got somebody, CN means cognitively normal. The red, yellow stuff in the middle is nonspecific. It's negative. To the extent we get mild cognitive impairment in the middle, dementia on the right, the redness in the scan implies that you have amyloid in your brain. And these are pretty good because people have done studies correlating the appearance of these scans with autopsy findings, and they're almost one-to-one. So very accurate. But as you can imagine, the world is not perfect. So you can have all combinations. You can have cognitively normal people, upper left, negative scan, bottom left, cognitively normal with amyloid in the brain. Similarly with the mild cognitive impairment in the middle column. So these are the kinds of situations that need to be evaluated by the long-standing research. Certainly going on here in Texas, the TARC program has evaluated these kinds of outcomes to see if, in fact, people in the lower left who are normal but cognitive but amyloid positive are going to progress to clinical impairment in their lifetime. And if so, when? Today, tomorrow, 5 years, 10 years, ever in your lifetime? That's a reasonable question. So here's what the brain looks like, looking at it from the left-hand side is the face, the right-hand side is the back of the head. The redness suggests the amyloid deposition in the brain. We can similarly do this with the tau imaging, the other defining feature. This is looking at the brain from the front on. On the left, that red-green stuff, nonspecific. On the right, we see the redness again, saying that this is a tau-positive scan. So the other defining feature of the disease is present in this person, irrespective of what the person's clinical condition might be. And here's a distribution with blue here implying distribution of the tau protein. So I said blood tests are on the horizon. They're here, they're being evaluated longitudinally, and we're trying to get a feel, is a blood test good enough? How can we use blood tests? Well, one would be to predict who might become cognitively impaired. We don't know when, today, tomorrow, 5, 10 years, we don't know, but prediction. We can maybe use them for the diagnosis. We don't have to do the expensive PET scans. We don't have to do the invasive lumbar puncture. We can do a blood test, say yes or no, maybe. And then, of course, with the disease-modifying therapies now approved by the FDA, we could possibly say, treat you, and we'll follow you with a blood test to see if the drug's working or not. We're not there yet, but that certainly is a reasonable possibility. So there have been many, many studies on these blood tests over the years. Here's a head-to-head comparison of a variety. Again, my lab, your lab, other labs do them differently. But basically, there is sort of a coalescence of information that is evolving as to which of these markers in the blood are most reliable and most valid. And here was a study published last year showing that, in fact, even in the primary care, your primary care doctor versus a specialist doctor, that these blood tests, again, the data here indicating that they're pretty good, that the blood tests are pretty accurate at defining who is going to have this amyloid protein in the brain. So that's the good news on the diagnostic side. I think we can get much more specific with our clinical characteristics, the continuum, normal, MCI, dementia. We can complement that with the blood tests, the imaging tests, the spinal fluid, to in fact document that the clinical syndrome is due to Alzheimer's disease. Now what do we do about it? Well, we're getting there. There have been two classes of drugs for Alzheimer's disease over the years: symptomatic drugs, disease-modifying drugs. The symptomatic drugs have been around for 20 plus years. These are drugs that work on chemical systems in the brain, boost certain chemical systems in the brain, to make them more active, to keep the person more functional, keep the memory alive a bit longer, but they don't get at the underlying disease process. Those are disease-modifying therapies, and thus far, they're focused on this protein called amyloid. Amyloid and tau, the two defining characteristics. 3 drugs have received some approval from the FDA on this: aducanumab, lecanemab, and donanemab. The MABs mean monoclonal antibodies. Aducanumab was the controversial one a few years ago that received early approval, accelerated approval by the FDA. A lot of controversy around it, but at the end of the day, they may have been leading us in the right direction. Basically, the controversy stemmed from one positive study, one negative study, one suggestive study. The FDA said, no, I think this is on the right track. So they approved it. That drug has gone through a lot of problems. It's off the market now, but it led the way. Followed up then by lecanemab from the drug company Eisai in Japan. And here we're plotting the removal of that amyloid protein in the brain. So the redness on those amyloid PET scans, on the top line there, we see no change because those are the people who got the placebo. But the bottom line is the amount of amyloid removed from the brain. And you can see it's rather dramatic. On the clinical side of the house, then, we have, again, a separation in the curves, not as dramatic, but nevertheless, solid demonstration that the drug appears to slow the progression of the disease. Doesn't cure the person, doesn't make them better, doesn't stop the disease, but it slows the rate of progression. And here are the details for that particular study showing that, again, 1,800 people, that almost all of the clinical markers were in the right direction, implying that the drug is really doing what it's supposed to be doing. The controversy in the field is that enough? Is that a big deal? Is a 26, 27% slowing of rate of decline over time meaningful to me as a patient? The drugs have side effects. On the bottom there, ARIA-E, ARIA-H, amyloid-related imaging abnormalities, either edema or hemorrhage. They can cause swelling in the brain. They can cause hemorrhage in the brain. There are protocols to monitor this very closely, but in uncommon situations, they take over the situation. There have been deaths in these treatment trials. So not many, a few here and there, but it has to be considered on an individual patient basis. The other drug, Eli Lilly, similar kind of picture. Here's the amyloid-reducing ability on PET scans of this particular drug. Again, the clinical picture, separation of the two curves, slowing of progression, 35%, 36% over 18 months. And here are the features. The ARIA rates, the imaging abnormality rates, a bit higher with this drug, although more recently there's been a new protocol with regard to how to deliver the drug at the beginning that may modify and reduce that risk profile. Both drugs do the same thing, and it becomes a one-to-one decision with the patient, family, doctor as to is this drug appropriate for you, but it can slow the rate of progression of the disease. Is that meaningful? Well, here's a theoretical depiction of that. The blue dotted line means the course of somebody who's untreated. The red dotted line suggests that this person's been treated and the drug is working. And the yellow box means this is the 18-month duration of a clinical trial. They're only 18 months. If the drug does what it's supposed to do, wouldn't you expect that to continue to expand over time? We don't know that, but theoretically, this would be the picture. And the way we portray that to patient in terms of preserving your current level of functioning. So if you're doing this today, we treat you with the drug. Can we keep you at that level for a longer period of time? So if you have mild cognitive impairment, you have amyloid in your brain, we treat you with this drug, and you're getting by, you're driving and doing things. Can we keep you there, driving for a longer period of time before you develop dementia? That's a possibility. Theoretically, that can happen, But again, it comes down to an individual patient discussion. So, at the end of the day, though, is Alzheimer's disease the end-all be-all? And the answer that's come apparent in the field in the last 5 to 10 years is no, not by any means. So here's the clinical spectrum: cognitively normal, mild cognitive impairment, dementia. If that is going south, what's impacting it? Well, it could be this amyloid protein we've been talking about. It could be the tau protein we've been talking about. This is Alzheimer's disease. But most people in their 70s and 80s who develop these cognitive impairment are likely to have other things going on. There's something called alpha-synuclein that contributes to a pathologic feature called Lewy bodies, the feature of Parkinson's disease. So Parkinsonism can creep into these pictures. Another protein called TDP-43. It's a misfolded protein that deposits in the memory part of the brain, the hippocampus. Looks like Alzheimer's disease for all intents and purposes, clinically, but it goes on very, very slowly without getting much worse, and this can very much be due to this underlying protein. Of course, almost everybody in their 60s, 70s, and 80s has a degree of vascular disease. Little blood vessels close off here and there. Blood flow is not as good. Some people have strokes, but even short of strokes, you can have vascular disease. There's another element called CSF dynamics of fluid in and out of the brain that can impact your cognitive function. And of course, there are other things we probably haven't appreciated yet. So this is the complexity of what's going on in most people aging with cognitive impairment. This is Alzheimer's disease. It's part of it, but may not be the whole picture. Maybe in any individual patient, this may be the key element, but it's likely that there are other things going on. Nevertheless, this is the kind of discussion that clinicians have to discuss with the patients and families to determine whether, again, we're talking about the drugs that intervene only on the top of that picture, the A-beta. That's the only element that these new drugs are impacting. So when you talk about a 27% slowing, a 35, a 36% slowing, is that a big deal? Well, in this complex picture, this may be as well as we can do intervening with just one of the pathologies. But where's the field headed? Well, here's the picture again. We're trying to develop biomarkers for each one of those elements. So we've talked a lot about amyloid, we've talked about tau. There are biomarkers under development for alpha-synuclein, the Lewy body component, and we learned today, and TARC research has contributed to the development of some of the biomarkers for the alpha-synuclein component. Can we define biomarkers for TDP-43? Vascular disease, MRI scans are pretty good. So we're trying to develop biomarkers for all these different elements. Why? Because we'd like to think that we could develop therapies. And it's ultimately going to be combination therapy down the road. Not a single drug, but maybe a combination of drugs. So if you have high blood pressure, what your doctor may give you a diuretic, a water pill, may give you a beta blocker to slow your heart rate down, may give you a calcium channel antagonist, may give you an angiotensin receptor blocker, may give you an angiotensin converting enzyme inhibitor. 5 different mechanisms, all treating that same symptom of high blood pressure. The high blood pressure here is cognitive impairment. And so we think that there are probably going to be multiple contributing factors so that maybe down the road, beyond my day, but in your day, it might be that you go into your primary care physician, she gets a lipid screen to see what your LDL, HDL, triglyceride levels are, and gets your cognitive screen, if you're having a little memory problem, to see what what might be the components to your cognitive picture. And that may be leading then to therapies in the future. So let me stop there, but I won't stop. I've got a couple minutes left, so I'm going to do a couple things and say, what can we do for ourselves? Is this all an end game with pharmacology? Not really. I think there was a report last year by the Lancet Commission in the UK that looked at the life course of all of us, and are there contributing factors to cognitive impairment the impacts of cognitive impairment at different points in our life. For example, in early life, education seems to be protective, so less education is a risk factor for cognitive impairment. Not Alzheimer's disease necessarily, cognitive impairment. Midlife, a whole bunch of things. If I can read these: hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol in midlife may contribute to your cognitive impairment in late life. Late life, social isolation, air pollution, visual loss. The bottom line here is that a chunk of these may actually be modifiable. We can do things for ourselves, midlife, late life, that will impact our memory and thinking down the road. So I think that the good news is, yeah, the pharmacology is moving along for the Alzheimer's specific components, but let's not forget these other lifestyle features that actually may be as important as these pharmacologic interventions. So there are things, we need not age passively. We can do things that will influence that. And here's sort of a theoretical discussion of how those different factors come into play. Got a couple minutes left here, and I'm going to leave some time for questions, but I sometimes end with a video of some of you may know of the country music star Glenn Campbell, who developed Alzheimer's disease. And he was diagnosed with Alzheimer's disease, did his last album, Ghosts on the Canvas, and as people, entertainers do, you know better than I, go on tour when they produce an album. And so, but in that interim, he was in fact diagnosed with Alzheimer's disease. So the question came up, do I go on the road? Do I go on the road with Alzheimer's disease, knowing what could happen and all that? He, the family, his band all sat down and said, let's do it. So he did it, and the family knew a couple of filmmakers, James Keach, Trevor Albert. These are the guys who did Groundhog Day and Johnny Cash films. So these are feature filmmakers. The family knew them and said, hey guys, come on over and let's shoot a few hours of film with Glenn. What do you think? And they said, come on, I'm going to go over and shoot film of a fellow with Alzheimer's disease. Not very exciting. 1,400 hours of film later, they produced the documentary, I'll Be Me. And it was really a testimony to Glenn and his family and all for their willingness to do this and to really kind of put it all out there, see how he experienced it, at the same time, how well he functioned in a structured environment. So, let me see, Rivers, if this one.
People say, is there no end to this man's talent?
No beginning.
Is there no beginning?
You know what the date is today? The month, the day, and the year. What month do you think this is?
What is it? I don't know. Let's go look.
Okay. What time of the year? Are we in winter, spring, summer, or fall?
I don't worry about those
Don't
things.
worry about that.
I don't worry about them.
All right. Do you know the year? What year is
that?
it?
1870, something like that.
No.
No, I don't pay attention to those things.
Okay.
When it's needed, I take care of that.
Do you know where you are right now? What's the name of this place?
I don't know.
What kind of a place is this? Where have you come?
Obviously, I'm being analyzed.
Okay. So what kind of an institute? What is this? Is this is it a hospital, medical facility? Mm-hmm. That's what it is. Okay, right. Who was the first president of the United States? Can you go back to your school years? Who was the first president?
My goodness, I don't know.
Okay.
I don't really use that very much lately.
Sure. I'd like you to try to remember 4 words, okay? I'm going to give you 4 words. You try to remember them now.
If, and but is my big one.
Those are later. Those are later. Try to remember these 4 words, okay?
Okay.
Apple.
Apple.
Mr. Johnson.
Mr. Johnson.
Charity.
Charity.
And tunnel.
And tunnel.
Okay. Can you give those back to me now?
No, I have no use for it now.
Okay. Any of them
I just already passed it.
that have gone already? Okay.
I can play guitar.
In a way, it's a blessing for his fans because we know that on down the line, we're not going to be able to go and see him and watch him perform. And so, you know, now is our opportunity to get out and to be able to see, you know, living legend.
Glenn and my dad were friends, and so his music filled the house, the Cash House. Music magically makes a difference in everyone's life. I mean, it's the fire that drives us on. You know, it's what gets us through our rougher, harder times.
I still cling to the fact that music does something to the molecules. I think that music is one of the only things that really collectively can change the molecules in all of us. And gosh, what an immense blessing to be able to have that impact on people.
Thanks. Whoa! Thank you. Woo! Thank you very much. God bless. I really appreciate it. 'Cause it's knowing that your door's always open and your path is free to walk. That makes me chin pull out. You got a thing right here. No, what is that? Where's that? You got to have one of those things on me because I forgot everything I learned. Is that? You got. I thought we had a thing because I forgot where A flat was, man.
Unfortunately,
We got
our
one?
teleprompter went out right at the top of the show. Seriously.
What?
Our teleprompter went out. It just.
Oh, I was wondering why that was. Has anybody here got everything? What do you call it?
We got it worked out. Hold on.
What?
We're gonna pull it up. Okay, ready?
Okay. 2, 3. Is it working? Hello! Oh, there we go! Yay! It's knowing that your door's always open and your path is free to walk. That makes me tend to leave my sleeping bag rolled up and stashed behind your couch. And it's nice knowing I'm not shackled by forgotten words and bonds, any claims that are lied upon some line. That keeps you in the back roads by the rivers of memory. It keeps you ever gentle on my mind.
Try a little kindness. You know, that thing has got this long guitar solo in it. Well, he's reading the teleprompter because he's pretty much reading the teleprompter for every song. He's singing and stuff, and he said, Glenn, play long guitar solo here. Okay.
I'll play one now.
of narrow-minded people on their narrow-minded streets. Pray for them! All the narrow-minded people on their narrow-minded streets.
You're plugging into something, some group consciousness. It's like you lose all self-consciousness, and it's just you, in a sense, are completely possessed by the music.
So it was an interesting observation of sort of a dissociation of his verbal skills and his motor musical skills, because, like Dan Truman said, you could play long guitar solo here. He was off and running. He had no problem with that. I mean, his musical skills did decline over time, but he needed that teleprompter for the memory of each of these songs he'd been doing for 40 years, yet he needed that teleprompter. So I applaud him and the family. 3 of the band members were his adult children. And so there was some criticism of him and Kim, his wife. Are you exploiting him, trying to make a few bucks at the end of his life, blah, 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 kind of stuff. And while those criticisms came in, the kids, the 3 adult children, said, told us that this was the best year and a half of their lives, because they got to spend that time on the road doing with Dad what Dad did for his own life. And so it was really, I think, a tribute to him, Kim, and the kids for willing to do this. One of the guys that was in the background there was a guy named Bill McClay, who's the stage manager. And when they were making the initial decision, he said, "Oh, geez, I don't know if I want to go on the road. I mean, it's going to be like going to a NASCAR race for the crashes, right? I mean, he's going to do something bad." And the bottom line was, we were at a number of these concerts over the years, people loved it. If he did Wichita Lineman twice, who cares? This is Glenn Campbell. This is the final tour. And so people loved him. So I think it was a great tribute to him and the family. So thank you very much to Monroe and Rita and Mrs. Abbott.